Good morning, everyone. I hope you all had a great weekend. Mine was good, though it felt a little bit short, but my husband and I managed to get all of the flooring out of the basement. We looked super cool in our fancy suits, and hopefully we didn't inhale anything too gross, but we had the fancy masks on. I had mine cinched down so tight that on Sunday morning I realized that I have a bruise on the top of my nose from having it cinched down so tight, so I should be in good shape. To start the day, what do you call a pig that knows karate? A pork chop. And because that's a horrible joke, I'll tell you one more. Why do bees have sticky hair? Because they use honeycombs. All right, those are your jokes for the day. So we're going to use this sort of rehab progression pyramid to frame the rest of the class. And if you talk about phases of rehabilitation, it's kind of going to depend on who you ask and what the person's impairment is. Your textbook uses 4 phases. The first being the acute phase. So if you're looking at acute injury, then we're talking about controlling pain and inflammation. And I am going to use this cool new tool that I got. And I'm going to put it in white because it's easier to see. No, I said white. Hold on. There we go. All right, so your textbook says you have the acute phase, controlling pain and inflammation. That's if you are talking about somebody who actually has an injury kind of at that moment that you are dealing with. So if you're not past the acute phase and you're moving into then what they call the intermediate phase. And in the intermediate phase, you're trying to start restoring range of motion. You're working on some of this mobility. You're still focusing also on controlling pain and inflammation. And then finally, once you've gotten back your range of motion, you're controlling pain and inflammation. Then you move into the advanced phase. And in the advanced phase, you're talking about working on strength, power, and endurance activities. So getting back to more of a normal active body segment for whatever was injured. And then finally, when you get through all those, then now we're talking about the ultimate, and that's function. Is this useful? Yes, but we're going to frame this in the form of a pyramid because if you're talking about somebody who doesn't have an injury, then this phase becomes sort of not useful. If you're talking about somebody who has a stroke, somebody who has a progressive neurological disorder, they're not dealing with pain and inflammation in an injury type of fashion. And this intermediate, this restore range of motion, we're just going to call that the bottom of the pyramid and talk about mobility and get into the advanced phase, strength, power, and endurance. We kind of lump that in together with function. We'll talk about strength and endurance and talk about function so that these kind of overlap and these kind of overlap. The book uses a lot of algorithms. They're very useful to have a if-then type of reasoning and help you to organize your thoughts. But really there is a lot of overlap. So I already drew 2 connections here. That's really true. As you start to work with people, especially people who have injuries and progressive neurological disorders, you end up going back and forth between a lot of these things, or you're focusing on several pieces of it all at the same time. So we're going to use them as a guide and sort of use them to cue yourself to remember the components of rehab, but don't think you have to follow them like a recipe book. So your clinical decision-making skills are going to be what's most important as you start to think through some of these different rehab factors. So here's our rehab progression pyramid. And as you can see down below, if I can get my pen to come back, we start this with mobility. So we're kind of skipping the acute phase. Now, we're not really skipping it, but if you are working with somebody who's has an injury, Then you sort of add this acute phase down here. And that's where you're talking about pain and inflammatory control. On Thursday, we'll talk about tissue healing and phases of tissue healing. So what are you looking for as far as controlling inflammation and pain? But if you are thinking about this whole pyramid, no matter who the person is, you're always going to keep an eye on pain. You're always going to be trying to control pain. Um, and if somebody has an injury that's in stages of inflammation, you're going to keep a tab on that too, but it ends up running sort of through this whole pyramid that you're always watching out for changes in pain and inflammation. If you're always looking at pain though, and that's kind of your top priority, you can get stuck in a space where you really can't do anything because it hurts, and you may need to get the person to work through some of that pain so that you can work through sort of that underlying issue. So if you think about having a massage, what do we say? We said it hurts so good. Sometimes you have to work through a little bit of discomfort for the sake of improving tissue mobility, range of motion, um, getting some strength back through a range of motion and working through some of those painful spots. My old rule working with athletes was on a scale of 0 to 10, 0 being no pain, 10 being I need to take you to the hospital right now. If you could keep it at a 4 or less, we'll try and work through it. I never had to break that rule. It's a good guideline. So if you can keep the pain at less than 4 out of 10, I try and work through that. That's not a hard and fast rule, but if you're always focusing on doing everything pain-free, you might get stuck in a rut and won't be able to move forward. So here we have our big base of the pyramid here, mobility. So here we're talking about range of motion, both active assisted, and passive range of motion. Strength and endurance, now we're getting into improving the actual force production of the joint segment and its ability to perform multiple repetitions of an activity. That's endurance. Then you get into function, and this is the one, remember, that's going to depend on what does that person's ICF model look like? What is their function? What do they need to be able to do? That's where you're going to focus on the function section. More realistically, if you can remember the old food pyramid, hang on. I have to turn the pen back on. If you remember the old food pyramid, it was a pyramid, but it had sections this way. It's kind of a good way to think about this if you have mobility here. You have strength and endurance. That was a horrible E. And here your function. You have to have one to do all of the others, sort of. You can do strength training without perfect mobility. So if you think about isometrics, you don't have to have a lot of range of motion to be able to do isometric activity. You can also do endurance activities without range of motion. You can maybe work on some function if somebody is working on reaching tasks, being able to do something like reach down and grab a sock or a shoe, or be able to get food up to their mouth from the table. Maybe you're not focusing so much on mobility, you're focusing on being able to reach, grasp, and move in some manner to be able to get food up to their mouth, or get a item from the floor to their lap, or put on and take off a sock. So just because it's a pyramid doesn't mean you have to wait until the entire bottom section is done to be able to move on to the second, to be able to move on to the third or the top section. It's gonna overlap a little bit, but by and large, this three-tiered. The first thing we're going to look at is mobility, then move into strength and endurance. Once we know that these are pretty good, then you move up into function. So mobility is the base of the pyramid. This is the flow chart from your book. I really like the flow charts in your book, so if you haven't looked at it yet, I highly recommend it. So if you are unfamiliar with this term, it's WNL. This is within normal limits. And when we're talking about mobility, we're talking about range of motion, both active and passive. So we have active, active assisted, and passive range of motion. You've heard those terms now. Active assisted range of motion being that the patient is doing as much of the movement as they can and then using some sort of external assistance to complete the range. Passive range of motion meaning not very much or no muscle activity during the movement. It's being done for them either by a therapist or some assistive device. An active range of motion, what can they do on their own? How do you know if it's within normal limits? Think about what you're going to learn in 412. You will learn what are normal ranges of motion for knee, hip, elbow, wrist, fingers, so on and so forth. And your book does have a table in there that has some normal ranges of motion, but we'll talk about that when we get really more specifically into mobility next week. Why do we care about mobility? Early motion after an injury or some sort of other disease or insult, if we get range of motion and other motion activities going early, you reduce muscle atrophy. If you reduce muscle atrophy, then you don't have as far to go when you start to get into that endurance and strength section. Your book says that type 1 fibers atrophy faster than type 2 fibers. That is incorrect. Type 2 muscle fibers are the ones that will atrophy the most quickly. If you just remember that muscle fibers atrophy with disuse, then that's all you need to remember, but they are incorrect. It is type 2 muscle fibers that atrophy more quickly. Also maintaining joint function. So if you maintain range of motion, you keep the function of that joint, which is it being able to move. All the cartilage and the synovial fluid and the ligaments and tendons are all going to stay more elastic. They don't start to sort of creep and get all different fibroses and scar tissue and such that prevent good movement. So if you keep them moving in the first place, it prevents that from happening and you don't have to spend as much time in this mobility section because they're already doing pretty well. Ligamentous creep, that's creep like as in somebody's creepy. And if I can get my pen to come back here, so C-R-E-E-P, creep. What happens with creep is that over time, if you have a ligament that's elongated, so say this is the normal length and it's resting at that point now, it's going to over time stay in that form and it can start to become even more elongated if that pressure over time is kept. So depending on how somebody is immobilized, you can have that ligamentous creep. If you keep a joint moving, the other thing is with cartilage and the tissue surrounding a joint, the vascularization and sort of that nutritive fluid that's in there. If you keep that moving, so in particular synovial fluid, you want to have synovial fluid moving around when it starts to sit in one spot. If you think about what a cup of juice or something looks like, orange juice in particular, if you leave it for a while, all of the little sediment pieces, so if this is liquid and when you first start drinking it, there's little pieces of pulp all around. If you let it sit for a while, they all start to gather on the bottom. So if you think about the little pieces of pulp being all the nutrients that are within your joint fluid, when you're sitting still, they just kind of sit in one spot. When you keep the joint moving, then they stay nice and distributed around the joint, and that is what we want. One thing to remember is that your body is inherently lazy. It's going to maintain itself only for the things that you are currently doing. So that's the use it or lose it. It will maintain itself for the activities that you are currently doing. So if your body is starting to assume that you don't need to have lots of joint nutrients and fluid and good extensibility of tissues, it's not going to stay that way. So continuing to move prevents that the changes within the joints and the muscles and the tendons and everything in between from just getting sort of all wound up and lazy and fibrotic and excessive scar tissue and such. So early motion is a good thing. The whole deal with passive, active, and or passive, active, assisted, active range of motion, most people consider that, draw over here, a progression that you have passive range of motion as the bottom of a pyramid, and then active assisted range of motion, and then active range of motion. Is it a progression? Yes. Or a hierarchy? Yes. But you don't necessarily have to do them in order. If somebody has active range and it's not contraindicated for them to be contracting that muscle, then it's recommended that they do active range of motion. If they're not getting towards the end of their range, then you can use an active assisted. If somebody really has no mobility at all, then no ability to contract the muscles, and that's where passive range of motion comes in. Or if muscle contraction is contraindicated or painful, then you can use passive range of motion. When somebody is moving, you want to pay attention to the quality of the movement. So it's not just that, Joe Schmo can get his knee from 0 to 90 degrees, but if they move in a nice smooth arc, that's one thing versus somebody who's going uh, uh, sort of this sort of chunky movement, and they're making a face, and it's really taking them a while to get to that top of the range of motion. That's a different quality of movement than somebody who has this nice smooth range. So we're attending to how are they moving, what does the patient look like as they're moving, and what's their response as far as pain goes. The goal for mobility, so overall goal is to establish and restore full pain-free range of motion. So restore pain-free, that's crossing it out, range of motion. Full pain-free range of motion is the goal when you're working on mobility. This includes your passive, active assisted, and active range of motion, but also joint mobilization, which is where you start to work on those accessory joint motions. So if you think about joint glides, and we're working into more of a not active movement of the joint, but working on sort of that capsular stretching, then that's where we talk about joint mobilization. We'll talk about that next week when we get into the specifics for mobility. Why do you need to have accessory joint motions? If you remember the functional reserve, we have your can do and your do. You want these two to be as far apart as possible. Well, if what you do is you need some flexibility of that joint capsule to move. If you have a little bit more flexibility in the joint capsule and the surrounding tissues, then when you actually do move, then you're not feeling that sort of tightness and gripping around the joint as you move. So that's when we start talking about joint mobilization and accessory joint motions, that's why that's important. Things to know. Flexibility is the amount of joint motion, joint play, and degree of extensibility of the particular connective tissues that cross the joint. So once again, the amount of joint motion, joint play, and degree of extensibility of the particular connective tissues that cross the joint. That's flexibility. Range of motion is certainly influenced by flexibility, but range of motion is also going to depend upon pain during the movement. If somebody has muscle guarding, where you have a involuntary contraction of the muscle due to pain while moving, if somebody is afraid of movement, that's called kinesiophobia. You're maybe thinking, who's afraid of moving? If you are somebody who has had an injury and you very vividly remember what exactly you were doing when that injury occurred, and let's say you tore your ACL shooting a right-handed layup. When you go back to shooting right-handed layups, there's a little piece of you that's kind of holding back. That is kinesiophobia, that you don't necessarily want to do that activity again because that's how you got hurt last time. It's very common in people with low back pain to have a kinesiophobia, fear of movement. So range of motion and flexibility are two different things. Are they related? Yes, but they're not the same thing. So flexibility is how much movement can happen at that joint when you take out the influences of pain, muscle guarding, the fact that somebody doesn't want to do it or is afraid to do it, so on and so forth. So remember, flexibility, what can the joint actually do? Range of motion, what does the joint do when the person is moving it on their own? If you have questions about the difference between range of motion and flexibility, be sure to bring that for our small group discussion on Tuesday. Peek real quick here at the hierarchy. We're going to get into this more next week, but so you have range of motion, mobility, are we within normal limits? If yes, we're within normal limits, then go ahead. We're going to move on to working on stability and performance. We'll call that the muscle strength and endurance section of the pyramid. If not, then we want to know, is somebody hypermobile, so they have too much joint motion? Then we're going to go to more stability. We put that in strength and endurance as well as function. Or are we hypomobile, have decreased motion? Here is where this gets a little more detailed than we're going to get into in this class, but it's worth pointing out. So a capsular pattern means that you identify a specific component of the joint capsule, so anterior, posterior, lateral, so on. That is restricted, so you have tissue fibrosis and such, and that's where you use joint mobilizations, and the grading of joint mobilizations mean how much movement are you trying to force in that joint in order to address the capsular issue. You do your treatment, reevaluate, did it get better? No, then try it again. If yes, then now we move on to more stability and performance. If you're hypomobile, decreased range of motion, and we're talking about contractile or fascial. So contractile is there muscle guarding? Is it from pain? Is there a myofascial issue, which we'll talk about when we talk about mobility specifically? Then we're looking at stretching and other soft tissue techniques and range of motion exercises. We're going to get into this specifically and do a lot of work on this in lab. Then again, reevaluate, did it get better? Yes or no? And then you move on. All right. Strength and endurance. So what your book calls this is stability and muscle performance. We're talking about strength and endurance. The stability component adds in a little bit more of the function if you're using the pyramid. The stability, muscle performance, and the next one, neuromuscular and function flowchart, are going to overlap for strength and endurance. And you got to remember that we're talking about restoring muscle strength, power, and endurance, yes, but also cardiovascular and cognitive, mental endurance. We're not just talking about being able to get somebody to move more weight. It's about also working on general wellness and being able to move well and continuously and have function. When we're working on strength and endurance, there is a hierarchy for progression of resistance exercises. And this is in your book, but I'll go through it for you. Single angle, submaximal isometrics in a neutral position. That's your very first one. And I will demonstrate some different exercises that would fall in these categories. So single angle, submaximal isometrics in a neutral position. Let's say if you had an elbow injury and you've been immobilized at 90 degrees and they're going to start working on some strength exercises, but you're not into a lot of mobility yet. So you're keeping the elbow at 90 and you're doing small bicep and tricep contractions, just a little squeeze in either direction without really moving. Multiple angle, submaximal isometrics at various angles of the range is going to come next. So now you've done your little squeezes, keeping the elbow at neutral. If you're going multi-angle, so now maybe you bend the elbow to 120 degrees or so, and you're doing your same isometric activities at that angle. Then you go to maybe 80 degrees of elbow flexion and do your submaximal isometric activities at those different points of the range. Moving up from there, still going with the multiple angle, but now we're doing maximal isometrics. So as much of a squeeze as somebody can give, now you're starting to push against, maybe the person is holding the hand with the opposite arm and pushing against their own resistance. You can use a table, a door, a wall, and so on. Once you've gotten to doing some of those multiple angle maximal isometrics, the next is submaximal short arc isotonic exercises. Now we're moving through a range of motion with resistance in a small range of motion. So short arc, kind of little bits of the range of motion, but we are moving through a range. Then into submaximal full range of motion isotonic exercises. Now we're moving some weight, not the most you can move, but some weight through a full range of motion. And then we have maximal short arc isotonic exercises. And you're going to keep moving through that short arc, getting more range of motion every time until you've reached full range of motion, maximal isotonic exercises. So moving through range of motion against resistance, and you're trying to move as much weight as you can for the given sets and reps that you've set up. Once they're moving through full range of motion with their maximal effort on weight, then you go into doing open and closed chain exercises in the isotonic mode. So now you're trying to start moving into more functional movements. And then isokinetics is something that I will show you during class when we talk about strength and endurance. Isokinetics, you use more sophisticated machines, may or may not see it in the clinic, but that is where somebody is moving against a given speed, and so set it at say 60 degrees per second, and they're pushing as hard as they can against a lever arm, and it's going to move at 60 degrees per second, and you can kind of measure as they go how is the person doing with that activity. So that is your hierarchy of progression for resistance exercises. I will walk through those with you in our small groups in class. If you have questions, make sure you bring those with you. I'm going to peek at their flow chart here for a second. So here's our question: is stability and muscle performance within normal limits? If it is, then we go on to more functional training. If not, then HEP, that's your home exercise program. That's in conjunction with what are you doing with them in the clinic. So I talked about isometrics come first. You're always going to be thinking about corrective exercise patterns. When we talk about the functional movement assessment, we'll start looking at where are you focusing your exercises and why. And isotonics, that's actually moving through a range of motion against resistance. Isokinetics, I just mentioned. Eccentric overload is going to come in towards the end of strength and endurance, and we'll demonstrate that when we get to the strength and endurance section. What can you mess with? The type of exercise, what position is the person in, what resistance are you using, sets and reps, so on. You're going to have a whole lab spent on this. Here's open kinetic chain and closed kinetic chain. Um, and this also puts in there whatever you choose. So what's going to be a good fit for that person based on what do they need. All right. And finally, function. So the goal for function is to restore neuromuscular efficiency and improve overall fitness and functional outcome of the patient. So restore neuromuscular efficiency and improve overall fitness and functional outcome of the patient. One thing that kind of gets left out in the first two components is talking about some of those lifestyle and behavior modifications that we talked about last week. When you're doing your subjective interview, you're trying to get at the whole person idea. What does their ICF model look like? What's their function? What's their environment? Or what are their needs? Those sort of lifestyle behavior modifications that you can do, such as sleep hygiene, improving nutrition, increasing physical activity, so on, that can get incorporated on day one before you've done even a single range of motion activity. You can incorporate lifestyle and behavior modifications. Your book saves that for the end of rehab. I would put that in much earlier in your rehab progression. The other reason that that can be important is because if you have somebody who is waiting for an immobilization period to end or to be able to start weight bearing, or they're waiting to get screws removed or something else, or they can't really do a lot in the physical rehab, then you can work on other behavioral modifications, health-related activities, while they're sort of waiting for that healing process to catch up. So maybe that's when you work on some cardiovascular conditioning using their uninjured body parts, or you spend some time talking about nutrition, or you do some stress management techniques. Those are all available to you. Talking about function and looking at neuromuscular and functional training, we start looking at motor control and motor performance. So what is the person doing? How are they moving? This becomes attending to how the person is moving becomes even more important in this functional training. As you start moving through, now we're getting into somebody who looks normal, but maybe you're getting into more sport-specific training. That's going to depend on the patient. What do they need to get back to? What are their demands of daily living? This is where some of that more functional training comes in. So sport-specific training comes in here. What do you end up working on? Lots of proprioceptive activities, working on motor control and performance in their specific activities. But as we talk about motor control, motor performance, those can also come in to the rehab program very early. If you think about somebody who's doing isometric strengthening activity and you're thinking about proprioception, somebody who maybe has had an ankle sprain, they can do single leg balance activities, can do isolated muscle contractions like scapular depression and retraction if you're working on posture. Those are all sort of lower level, more proprioceptive activities, but they still fall under this neuromuscular motor control, motor performance type of exercises. And we're going to talk about that a lot more when we get into this actual function section. So if you'll peek at their flow chart here. So are we within normal limits? No. You still have your home exercise program. PNF is proprioceptive neuromuscular facilitation. We'll have a whole lecture on that from Professor Ponke. Here they're including balance training and other neuromuscular re-education exercises, plyometrics, and activity of daily living or sport-specific training. This is getting up towards the higher end of, or kind of wrapping up being in rehab, getting back to normal function. Goes beyond just these sort of the lower level activities that you can do earlier in the rehab process, plyometrics and sport training closer to the end of the rehab process when you're about to discharge them. And so here now, if we've reevaluated and yes, everything's better, then DC, that's discontinue, and you can discharge your patient. So that is the rehab progression pyramid. We will use this model for the rest of the class. Those flow charts are going to come up again. They're good for decision making. Remember that they're not hard and fast rules, but they're a good place to start. Make sure you bring questions for me for our small group discussions on Tuesday, and I look forward to seeing you then. All right, everybody have a great day.